Okay, thank you. Thank you very much. It's important to identify scleritis because it's often associated with a serious, potentially life-threatening vasculitis. And as you mentioned, like in Wagner's or PGA, if you don't identify the condition, there's an 80% mortality rate. Also, they're treated differently. Scleritis is treated with systemic medication. Episcleritis is different. You can see here the blood vessels, the radial blood vessels and the superficial episcleral vessels are prominent and swollen. And that's going to look different than what you see with scleritis. I'll go over that later. But this chart here compares scleritis with episcleritis. With scleritis, you can really get destructive loss of scleral tissue. With episcleritis, there's no loss of tissue. Often, scleritis is painful because the scleral inflammation involves the nerves going through the sclera. With episcleritis, patients will complain of some irritation for a few days to weeks. Scleritis is very uncommon. It's about 3.4% cases per 100,000 person years. Episcleritis is more common than, much more common than scleritis, but less common than what you find in uveitis in the community. And I circled that in red, but I had a typo in the handout. Episcleritis is not usually associated with any systemic disease, and generally we don't do laboratory workup for episcleritis. Scleritis we have to treat with systemic disease. Episcleritis we will give topical steroids. So how do you tell the difference clinically? As in the other slide, in episcleritis you see these large superficial episcleral vessels. And with scleritis, you don't see these radial vessels, but underneath this swelling and edema, there's a network or a meshwork of deep episcleral vessels that are inflamed. Now, when you have a patient with a red eye, how do you know which layer is involved? When you have the conjunctival vessel layer, you have the superficial episcleral vessel layer, and the deep episcleral vessel layer, all on top of each other. Well, we put a drop of phenylephrine, 2.5%, and that blanches the surface vessel, the conjunctival vessel, so you can see whether the deep episcleral vessels, the network, the meshwork of the deep episcleral vessels are inflamed. Another clue that you have scleritis is that sometimes you see a white halo around the cornea where the rest of the sclera is inflamed, and that demonstrates there's a different blood supply between the deep episcleral vessel and the blood supply of the limbus. Now, what is scleritis or episcleritis? Well, often you will see patients with a pinguicula, and sometimes we call that pinguiculitis. That's not a true episcleritis. And of course, in the differential of patients with a red eye, you see patients with adenoviral conjunctivitis, with inflamed tarsoconjunctival vessels. Now, with scleritis, it's important to determine which form is scleritis. So I'm going to show you the four major forms of scleritis, because it's very helpful to know what form, because that will help you decide how to start your treatment. Unlike uveitis, treatment of scleritis is not necessarily a stepwise program. Here you have examples of diffuse anterior scleritis. Here you can see the redness. There, sometimes it takes on a purplish film here. Another case of diffuse scleritis. Here, this is a nodular scleritis. This is a little bit more advanced form. The sclera becomes edematous and thickened and infiltrated with white blood cells. So you get this thickening here. This is a more serious form there. And here's another case of nodular scleritis. This is the most severe form. This is a necrotizing scleritis. This is where the deep episcleral vessels become so inflamed they become obstructed. You get an ischemic process. In addition, you have polys coming in. And polymorphic nuclear leukocytes contain collagenase, which breaks down the collagen in the sclera. You know, this is a very sight-threatening condition. Another case of necrotizing scleritis. This is really a white patch surrounded by redness here. The outcome of necrotizing scleritis is that the sclera is thinner. So when you see a patient who's had necrotizing scleritis, you're going to see blue patches, you know, because you're actually seeing uvea through the sclera. This is a particular subset of necrotizing scleritis. This is scleromalacia perforans. This white area looks like putty, and this is necrotic collagen there. And there's no inflammation there because there's no blood vessels. They're occluded. And there's different stages of this necrotic scleritis, and sometimes the sclera becomes thin. You would actually feel like that you're going to get a perforation, you know. In some cases, there's just a very thin viral network holding the uveal back, and the uvea is bulging out like a staphyloma. The last form of scleritis you need to know is posterior scleritis. And here you see a patient with a serous rectal detachment here. And before we had fluorescein angiography, and before we had ultrasound, and ultrasound of the eye really was developed at the beginning of my career. You know, these eyes were removed because sometimes they were thought to be a malignancy there. They were removed because of the suspicion of a melanoma there. Fortunately, with the development of ultrasonography, particularly B-scan ultrasonography, that has helped us to rule out tumors, and it helped us note that behind the sclera there is area of edema, which I'll show you better here on it. Here, a B-scan ultrasonography. On the picture on the left, you see the black line behind the sclera, and that's edema fluid. And when you have in your image the optic nerve, it creates a T-shaped sign. So one of the classic things you see, one of the frequent things you see on OCAP is a T-shaped sign in cases of posterior scleritis. Now, scleritis can involve the cornea, and one of the things you see is peripheral ulcerative keratitis. You see this in rheumatoid vasculitis, and you see it in PGA. And what we witness here in the cornea is probably immune complexes that have come from the limbus into the cornea. And that's why this furrow is parallel to the limbus. And when you have immune complexes, they attract polys. Polys bring in collagenase, and that's where you have the thinning. Causes of scleritis are the two main things: immune-mediated and infectious there. And I listed here from an old report a series of 73 cases of scleritis. And you can see the most common systemic condition associated with scleritis is rheumatoid arthritis, then Wegener's, and further down, relapsing polychondritis, and ulcerative colitis. And the rest were not worth adding to the list here. Infectious causes, it should be always considered. The typical story is someone working out in the field, they get branch in their eye, or some plant material would scratch their eye. And you have to consider infections like nocardia, that branching bacteria, that. One of the things more recently for me is to learn that I can have a patient with scleritis, and it could be a herpes simplex virus causing it, and there'll be no dendrite there. And I learned this when a patient came in with chronic scleritis. I started off with prednisone, moved into immunomodulatory drugs, and the scleritis persisted. And this is a unilateral scleritis. And she surprised me one day, and there was a dendrite on the cornea. So I gave acyclovir, the dendrite cleared, as well as the scleritis. And it's very hard to know if the herpes is a cause of scleritis, because you can't do swabs of the tears, it's just, contamination issues. PCR is not very helpful. So sometimes with a case of unilateral scleritis, I'll ask about the history, if there's any past history of cold sores and things, and I may just give a trial of 2 weeks of acyclovir to see if that will help with the scleritis. And there's also systemic infectious causes of scleritis, like syphilis and TB. And with rheumatoid scleritis, it's worthwhile getting rheumatoid factors and anti-CCP, but they're often elevated. When a patient has rheumatoid scleritis, they really have a rheumatoid vasculitis. We talked about Wenger's, and here's an example of peripheral ulcerative keratitis. Associated with Wenger's. Other findings is a saddle nose in patients with Wenger's. Now, infectious scleritis, I want to bring up, is very difficult to treat because the sclera is really avascular. And most of the antibiotics we give is delivered by way of the blood vessels. If in the case of the cornea, the treatment is Bactrim, and the like. Treatment of scleritis is we usually start off with steroids, and generally we start off with 1 milligram per kilogram of body weight on it. We try to avoid use of topical or periocular steroids. It was once felt that if you give a periocular steroid injection in a patient with scleritis, that the steroid would trigger melting of the sclera. But in recent years, some ophthalmologists are giving periocular steroids for scleritis, and they're particularly staying away from the area that's most inflamed. Cyclophosphamide was, and probably still is used, to treat patients with rheumatoid vasculitis or GPA when they don't respond to prednisone. More recently, we've been using rituximab, and this is a chimeric monoclonal antibody against CD20. It seems to be effective, but it does affect the bone marrow. And when I first used Rituxan, more than 10 years ago, we were very fearsome, and we would only give initial treatment and followed by another treatment a couple months later, and that was kind of like standard. But today, Rituxan is more widely used, and I was really surprised when I was reviewing the literature on oculocyclical pemphigoid and other picocoid disease that Rituxan can be given even on a monthly basis, along with IVG, IG. Oh, really? It's incredible. If you take a look at the cost of these drugs, and you take a look at even a common drug like Humira, which is given every 2 weeks, That's about a $4,000 or $5,000 a month. And we were talking about Acthar, and that's worth about 80,000 and 100,000 for Quan. What's the price of Acthar?
So right now, without insurance, about 20,000 a month.
20,000 a month. Yeah.
So definitely, I think that's the reason why we don't consider that as a first line therapy in many cases.
Okay. So the treatment of scleritis I mentioned earlier is not a stepwise pattern. If you see a patient with a necrotizing scleritis, you don't start off with a NSAID, You need to start off with immunomodulatory drugs at the beginning. You need to start off with either Cytoxin along with steroids. What you want to do is save the tissue that's melting away. Treatment of infectious scleritis is difficult. You load the patient up with systemic and topical antibiotics, but realize that 1/3 of the patients with infectious scleritis will eventually lead to a nucleation. Episcleritis is treated with topical steroids 4 to 6 times a day. Usually the condition resolved, but there's a few cases that tend to be chronic. And at that time, I would add a topical NSAID or give them a systemic oral NSAID. So in my 15 minutes, I think I got it.